It's a little bit after 7 o'clock, so I think I'll get started. Good morning, everyone. I'm one of the pediatric neurosurgeons at Nicklaus Children's Hospital, and today I'll be speaking about insular epilepsy and reviewing our center's 20-year experience managing this condition. I'm quite interested and excited about this topic, and I hope that at the end of the hour, you'll have a greater understanding of the features of insular epilepsy, recognize it in your own patients, and be able to understand the ways of surgically managing it. So a couple objectives from this talk. First of all, I'd like to discuss the history and background of insular epilepsy and reviewing the evolution of the discovery of the insula from 1809 by Real to the description of the insular epilepsy in the 1940s by Fenfield, and later experimentation of insular resection from the early 1940s to 1960s. Secondly, I'd like to review the anatomy and connectivity of the insula with you, and then also understand the clinical features of insular seizures in adults and children, and to review the many ictal spread patterns of ictal epilepsy and the types of seizure semiologies of the insular seizure and the insular opercular seizure. Fourthly, I'd like to discuss the methods of insular sampling during phase 2 evaluation, and those are SEEG implantations or subdural grid implantations, so invasive EEG implantations specifically to look at the origins of the epilepsy. And then lastly, discuss the Nicklaus Children's Hospital experience with insular sampling and surgeries for epilepsy. So the insula is really completely covered tightly by the adjoining frontal, parietal, and temporal opercula, and it's got a dense vasculature wall of surrounded by a middle cerebral artery in addition to the sylvic branches. The insula was initially described by Johann Christian Real in 1809, and he called it the island of Real. However, the anatomy and the function of the insula remained poorly understood until the last century. And when the first edition of Gray's Anatomy was published in 1858, Henry Gray named this region Island of Real to recognize Johann Christian Real's recognition of this area of the brain. Over the years, the insula has been given many different names since Real first described it, and it's been previously called central lobe, fifth lobe of the brain, intersylvian convolutions, and intralobular gyri. And it was really Penfield who first described insular epilepsy in 1946 at the Ferrier Lecture of the Royal Society. And Penfield was really a very remarkable neurosurgeon who made a significant contribution to epilepsy surgery. He studied under Harvey Cushing and later obtained a position at the Neurological Institute of New York, where he carried out neurosurgical procedures for epilepsy. And while in New York, he met Rockefeller, who later endowed and funded the MNI, or the Montreal Neurological Institute. And in 1934, Penfield became the founder and the first director of the MNI. And he was best known for treating patients with severe epilepsy. And before operating, he would stimulate the brain with electrical probes while the patient was conscious under only local anesthesia. And in this way, he was able to accurately target areas of the brain responsible for epilepsy. And therefore, he was also credited to creating the cortical homunculus. And these are pictures of Penfield, the Montreal Neurologic Institute, and of course, his famous work, Epilepsy and Functional Anatomy of the Human Brain. And so interestingly, Penfield was probably one of the first neurosurgeons I've ever heard about. I think I was in elementary school when I first heard about Penfield, not because I knew anything about neurosurgery at the time, but because he was featured on Canada's Heritage Minutes. And maybe Dr. Levy and the other Canadians might remember this, but the Canadian Heritage Minutes was a series of 1-minute clips produced in the 1990s, featuring some of the most famous Canadian stories. And it's really when Wilder Penfield became a household name. So let's see if this clip is going to be able to show.
So, toast is burning.
Toast is not. Every time she has a seizure, she smells something burning. Now, if we can provoke that smell by probing the surface of the brain, we'll find the source of the seizures. Mrs. Gold, do you feel anything?
I can see the most wonderful lights.
And now what do you feel?
Did you pour cold water on my hand, Dr. Penfield?
Now what? What is it, Mrs. Gold?
Burnt toast. Dr. Penfield, I can smell burnt toast. Dr. Wilder Penfield. He cured my seizures and hundreds more. They say he drew the roadmap of the human brain. We just called him the greatest Canadian alive.
Okay, so that was just a little clip. Obviously, it was a dramatization of one of his works, but it kind of gives you an understanding of how well respected he is in Canada and also in the neurosurgical field. So in 1967, Penfield was made a champion of the Order of Canada. He died 9 years later and was designated National Historical Person in 1988 by the Government of Canada. And today, you'll still remember him through the human homunculus, and then, of course, all the Penfield instruments that you use on a daily basis in the operating room. So as we understood more about insular epilepsy, it was really first described then in literature in 1949. And over a period of time between 1949 and 1960, insular resections were performed as a complement to temporal lobectomies based on the presence of interictal activity recorded in the insular cortex during intraoperative ECOG. And what they could concluded from the surgeries that they had done in the 1940s, 50s, and 60s was that, first of all, insular resections did not improve the success rate of surgery. Secondly, the post-surgical outcome after insulectomy was the same regardless of the presence or absence of post-excisional insular ictal activity. And number three, the incidence of complications was nearly tenfold after insular resection than temporal lobectomy alone. And therefore, really from 1960 to the early 2000s, insular epilepsy and surgery entered this period of lull, and for nearly 4 decades. And all the meanwhile, our knowledge and understanding of other focal epilepsies, including temporal epilepsies, frontal epilepsies, really progressed regularly without such a disruption. And the main reason for this lull in insular exploration during epilepsy surgery is really anatomic, right? Because the insula is hard to assess and directly implant. And the insula is buried under the frontal, parietal, temporal, opercular cortices, and thus precluding the scalp recordings from spontaneous insular seizures. So furthermore, the insula is covered by a dense vascular web of vasculature and long considered inaccessible through Ddavp electrodes during SEEG. However, that's about to change in the early 2000s. And I think, really in the early 2000s, insular epilepsy entered this modern era where the semiology of insular epilepsy remained unknown, but much greater recognized in the early 2000s because of our ability to use MR-guided implantation of intracortical electrodes that permitted the first recordings of insular seizures. Furthermore, we had great advancements in non-invasive investigations, including MRI, functional MRI, PET, SPEC, MEG, that really enforced the concept of insular epilepsy by revealing structural and functional abnormalities associated with insular seizures. And then, of course, recent advances in surgical techniques, including SEEG, MR-guided LIT, radiofrequency thermoablation, now offer patients with insular epilepsy the opportunity for seizure freedom. So essentially, although we did not quite understand insular epilepsy back in the 1940s, 50s, and 60s, we are starting to have greater understanding of it over the past 20 years. So we've understood that because of the complex cytoarchitecture, functional connectivity of the insula, that structure is essential for emotional social adaptation, stimulus detection, vegetative control, homeostasis, and cognition. And although open surgery and its complications back in the 1940s and 50s led to an initial abandonment of insular resection, recent advances in surgical techniques have really allowed us to understand this entity a lot more. So here are some of the advancements that we've made in the modern era. we've recognized that the insula, like any other cortical region, can be involved in seizure onset or during the propagation of seizures and from other cortical areas. And this basically is most well recognized in a temporal lobe or so-called temporal lobe plus epilepsies. And therefore, it is essential to really know the timing of ictal insular involvement as assessed by ictal electroclinical data to delineate the seizure onset zone to be resected by surgery. Second of all, some insular seizures are actually insular opercular seizures, whereas others are clinically silent and manifest clinically when seizures discharge has propagated to distal brain areas. And that's most demonstrative example of that is that when seizures with frontal presentation originating from the upper anterior portion of the insula then propagate to the frontal cortex. And thirdly, if no single symptom is specific per se of an ictal involvement of the insula, some sequences of symptoms are now clearly identified, indicating that the insula should be explored before planning a surgical resection because it participates, albeit alone, in the building of some ictal semiology. So moving on to the anatomy of the insula. The insula is anatomically divided into an anterior part that comprises of 3 short gyri, which are the anterior, middle, and posterior gyri, and then a posterior part that comprises of 2 long gyri, which are the anterior and posterior gyri. And it has 4 different functional areas: cognition, cognitive, social, emotional, chemistry, sensory, and sensory motor that overlap. And despite its name, the insula is not isolated. It's rather highly connected brain region, and therefore seizures originating from the insula are great mimickers of seizures originating elsewhere. And a little bit about the connectivity of the insula. It's a very complex structure, and it's involved in a wide range of functions and connections. It was initially studied in non-human primates. However, in recent years, we've had more and more understanding of the connections of the insula. And this is some of the work by Gaziri in 2017. So this group assessed the structural connectivity of the insula using the latest state-of-the-art high angular resolution diffusion imaging tractography algorithms. And by performing this type of tractography, they were able to analyze 46 young normal adults to reveal the different kind of connections of the insula. And this study really revealed a wide array of connections between the insula and the frontal, temporal, parietal, and occipital areas, as well as the limbic areas. And furthermore, they revealed for the first time in humans a clear structural connectivity between the insula and the cingulate, parahippocampal areas, supramarginal and angular gyri, as well as precuneus and occipital regions. So really some of the work that we've done over the past few years have further allowed us to understand the connections between the insula and other regions of the brain, and to be able to understand and to evaluate these seizures that are coming from the insula. This is some of the understanding from functional state, resting state functional MRI. And basically this shows that the human insula is functionally involved in 2 distinct neural networks. So first of all is this anterior pattern that is related to the ventralmost anterior insula and is connected to the rostral anterior cingulate cortex, the middle and inferior frontal cortex, and the temporal parietal cortex. And then secondly, this posterior pattern, which is associated with the dorsal posterior insula and is connected to the dorsal posterior cingulate, sensory motor, premotor, supplementary motor, temporal cortex, and some occipital areas. And really these 2 neural networks likely subserve different functions. The first, an emotional salience detection and attentional control related pattern related to integration of multiple cognitive, homeostatic, and emotional functions. And the second pattern really linked to skeletal motor body orientation, environmental monitoring, and response selection. So depending on the semiologies that we see in our patients, we may elect to sample either the anterior portion of the insula or the posterior portion of the insula. And now we're really understanding more about the function of different portions of this structure, which is highly complex. Furthermore, we've now made progress in the understanding of the insula and its link to language networks. So despite the insula's location in the epicenter of the human language area, its specific role in language is not really sufficiently understood. The left insula has been related to a diversity of speech and language functions, including articulatory planning, language repetition, and phonological recognition. And through this study of Ardila and al., 13 different activation clusters were found. The insular connections were included, not only areas involving the language production, such as Broca's area, and language understanding, such as Wernicke's area, but also areas involved in language repetition, such as the supramarginal gyrus, which you can appreciate through the brain network of the insula. And also you can see with this artist rendition, you can see multiple connections between the insula to different regions of the left hemisphere. So how does insular opercular epilepsy spread? There have been multiple recognized patterns of insular opercular epilepsy spread, and through intracranial studies, we have made great strides in understanding the different types of seizure spread of the insula, and that includes a very classic Paracellular clinical pattern. But in addition to that, it can also manifest in a temporal-like spread pattern with symptoms that include altered awareness and oral elementary and manual automatisms. It can also spread in a frontal pattern and include hyperkinetic behaviors or tonic motor signs, and even with epileptic spasms. Insular seizures can also spread to the contralateral hemisphere quite quickly because it's considered a deep structure. So therefore, this understanding of the different kinds of spread patterns really supports the idea that insular epilepsy can be a great mimicker, depending on the pattern of seizure spread. And the semiologies of seizures generated by insular lesions is often described as similar to temporal or frontal semiology. But as I mentioned previously, it can manifest with spasms and even contralateral spread very quickly. However, there are some specific characteristics of insular seizures that include vegetative, somatosensory symptoms, according to the complex physiology and extensive connections of the insular cortex. And then on the other hand, there are some aspects of temporal lobe seizures that may be related to the involvement of the insular cortex. And this includes something like epigastric aura, where the patients will have they will describe abdominal discomfort or a classic epigastric rising sensation from the stomach all the way to the throat. And those are classic temporal lobe seizures, but it may involve the insular cortex. And the close connections of the insula with other potentially epileptogenic areas, like the temporal mesial structures and the frontal central cortex, can be considered a reason for misleading findings on EEG and invasive investigations. So how do we further understand or sample or resect the insula surgically? In some cases, of course, of a tumor involving the insula or a clear lesion involving the insula, we will proceed to resection without sampling. However, in the majority of the cases, because of the reasons I mentioned previously, it's very deep. It can propagate to many other areas, and it can manifest in different kinds of semiologies. It's difficult to discern for sure whether a seizure is coming from the insula or involving the insula. So in the majority of the times when we're talking about pediatric epilepsy surgery, we will consider invasive EEG monitoring and sampling the insula first before we commit to surgical resection. And because these different semiologies are difficult to assess, we frequently will proceed to phase 2 evaluations or invasive EEG evaluations to better understand the networks and also the involvement of the insula. So in brief, there are two different ways we can sample the insula or any other type of the brain through invasive means, and those are collectively called phase 2 evaluations. Phase 2 evaluations are invasive EEG evaluations, and this is in contrast to phase 1 evaluations, which are considered non-invasive evaluations that include scalp EEG, video EEG, functional MRI, SPECT, PET, MEG, TMS, neuropsychological testing. So those are phase 1 evaluations that are non-invasive in nature, and phase 2 evaluations are invasive in nature. So phase 2 evaluations consist of either subdural grid and strip electrode insertions or SEEG insertions. So first of all, a little bit of background about subdural grids. It's placed directly on the superficial cortex through a craniotomy. So you'd have to do a large craniotomy in order to place these implants. And they include grid, strips, and depth electrodes that you can place directly onto the brain. And with grid electrodes, there are continuous arrangements of electrodes that covers a large area of the cortex, and high density coverage of key eloquent areas allows for extensive functional testing and mapping with cortical stimulation. So that's kind of some of the benefit of subdural grid electrodes. And sometimes during the process of implanting a grid, we will either place a depth electrode onto the insula using a freehand technique, or alternatively dissect through the sylvian fissure and place a contact electrode over the sylvian fissure directly over the insula. The second type of phase 2 evaluation that we will employ would be SEEG. And it's much more less invasive, minimally invasive procedure for the insertion of depth electrodes into the brain, and basically it consists of stereotactic implantation of multi-contact intracerebral electrodes for 3-dimensional sampling of the seizure onset zone. And compared to subdural grids, SEEG is safe, less invasive, and has decreased risk, of course, of infection, CSF leak, etc. So this is an example of subdural electrodes that for a patient with insular epilepsy. So as you can see here, in the process of putting in grid and strip electrodes, we could split the sylvian fissure and then drop a contact electrode, either a depth electrode with multiple contacts or strip electrode with multiple contacts directly onto the surface of the insula. And really there are different types of subdural monitoring of insular sampling. So one of the techniques, as I mentioned before, is this transsylvian technique where we open up the sylvian fissure. We can also employ a transcortical technique that we can use with a temporal resection or implantation, and resection or implantation and sampling of the insula through a transcortical approach, and then also the subpeel approach for assessment of the insula as well. When it comes to SEEG, insular implantations, there are multiple different ways and approaches that's been described in literature and that we use at Nicholas Children's Hospital for investigating insular epilepsy. And this is some of the work from the Cleveland Clinic experience, which has one of the largest cohorts of SEEG data in the adults. So this is 198 consecutive SEEG implantations with more than 1,500 electrodes implanted over a 4-year span at the Cleveland Clinic. And really the authors, Omar et al., identified patients with suspected insular involvement based on seizure semiology, scalp EEG data, and preoperative planning. And of their 198 cases of SEEG implantations, 135 of them, so the majority of the patients actually had implantations. So that's a total of 303 electrodes inserted into the insula. So they have a very significant experience with insular epilepsy sampling. So what they were able to say is that the majority of the electrodes, so more than 88% of the electrodes, were inserted orthogonally through this approach here. So the orthogonal approach directly through the frontal parietal or temporal operculum. And about 11% were implanted by means of an oblique trajectory through the frontal or parietal entry point. In about 14% of their cohort, they sampled the insula bilaterally, so they had bilateral insular electrodes, and in 17% of the cases, the insular epilepsy implantation groups was confirmed to be involved during SEEG. And none of these patients, in their extensive experience of insular sampling, had any kind of complications from the SEEG insertion. So none of them experienced any kind of neurologic deficits or hemorrhage. And they also have spoken more about the seizure outcomes following insular resection, in that 5 patients were able to achieve angle 1 classification of complete seizure freedom, and more commonly we had patients who had either angle 2, 3, or 4. So in addition to this approach, the orthogonal or the oblique approach of SEEG implantations described from the Cleveland Clinic, there's multiple other groups that have described different types of approaches for sampling the insula. Specifically, this type of parasagittal posterior oblique approach described by different authors involve insertion of these electrodes into the insula from a parietal occipital parasagittal entry point. And in addition to that, there is the coronal anterior oblique approach, where there is insertion of a depth electrode through an anterior frontal entry point. And specifically, the advantages of these oblique anterior or posterior approaches is that they're relatively safe trajectories through usually non-eloquent cortex. And additionally, the trajectory passes through the insula, which is a C-shaped structure, in a more angulated plane, allowing for several contacts to reside within the insula, allowing us to further capture insular activity and to further understand the exact area of seizure origin, and to be able to have more coverage of the insula through these contacts. This is also, this type of approach, for example, the coronal anterior oblique approach is also particularly useful in a commonly seen scenario where there's ambiguity of the role of insula versus the frontal lobe in seizure contact. So when we speak about the history of the insula, we then move on to talking more about our specific experience at Nicholas Children's Hospital. And Nicholas Children's Hospital is really an extremely strong epilepsy program, and it has a long-standing history of epilepsy surgery. So since its first epilepsy surgery in 1979, the Nicholas Children's Hospital Comprehensive Epilepsy Program has performed a lot of state-of-the-art work in pediatric epilepsy. So it's been an early adopter of functional MRI, transcranial magnetic stimulation or TMS, and also electric source localization serial EEG. And this program has further advanced the understanding of resting state functional MRI and epileptic networks. It's participated in the initial responsive neurostimulation trial, and also one of the first to describe MR-guided lit cases in the pediatric population. And then, of course, the first in the world to perform magnetic resonance guided focused ultrasound for the pediatric population and in central brain lesions, such as hypothalamic hamartoma. It was also the program that first started performing subdural grid implantations in the early 1980s. And we first performed SEEGs in this program in 2015. And later in 2020, we acquired the ROSA robot. So we've recently just reassessed our large experience with SEEG, and we're able to identify quite a few patients assessed who had insular epilepsy assessed through SEEG and subdural grid electrodes. And we first recognized the value of understanding the insula for epilepsy, and we first began insular sampling in the early 2000s. So this is a little bit of preliminary data from a very brief retrospective review of our phase 2 implantation and sampling cases. So as you can see, the role of the insula in epilepsy was first recognized in early 2000s. And then that's when we started to interrogate and sample the insula during phase 2 evaluations. So these type of evaluations really started to pick up at around 2005. And over the years, we have had more and more patients be implanted, have their insula implanted. So you can see here the total number of phase 2 evaluations are the accumulation of these two bar graphs. But in the early years, the majority of the patients who did not have insular implantation. And you can see with the blue, which is patients with insular implantation, you can see the number of insular and the proportion of insular implants really increase over the years. And over the past couple of years or so, between 2020, 2021, we were more often interrogating insular epilepsies and the role of the insula in epilepsy than not. So you can see the number and the proportion of the blue insular implant as a proportion of overall implants really increase over the years. And when we look at the proportion of insular implants between 2005 and 2021, we have performed a total of 276 phase 2 evaluations, and that includes subdural grid electrodes insertions and SEEG electrode insertions. And of this cohort, 66 patients underwent insular sampling. So that's nearly a quarter, so 24% of phase 2 evaluations. And as I mentioned previously, the number of insular evaluations have really increased over the years. And 49 of the 226 patients with subdural implants had their insula sampled. So that consists of approximately 22% of patients with subdural electrodes. And 17 of the 50 SEEG implants that we have performed during the same period had insular sampling, and that consists of 34% of SEEG implantations. So when we're talking about 22% of subdural grids involving the insula and 34% of SEEGs involving the insula, that significance approaches statistical significance. And so that is to say, we are doing quite a few more insular implants through SEEG compared to subdural electrodes implantations. And this is just an illustrative example of one of the cases that we managed at Nicholas Children's Hospital. And this is one of the 49 cases of insular implantations that we have performed using the subdural grid and strip implantation technique, where we do a craniotomy. So as an illustrative example, this is a child with invasive insular monitoring through the subdural electrode implant. You can see here on the preoperative coronal MRI, there is a cortical thickening of the right insula, and the patient also has seizure semiologies that were consistent with possible insular origins. So I believe this child had tachycardia, facial flushing, in addition to this laryngeal or pharyngeal throat sensation that's commonly spoken about and discussed in insular epilepsies. So with this case, we suspected that the insula was involved with epilepsy. So during the surgery, a craniotomy was performed. The right-sided hemisphere, as you can see here, was visualized, and the sylvian fissure was split, and an insular depth electrode was placed through an avascular portion of the insula directly posterior superiorly. And then lastly, after the implantation, we have a co-registered CT and MRI image. So this is basically a post-operative CT that shows the insular implant, then fused to a preoperative MRI. So this co-registered CT and MRI image shows the position of the insular electrode. And as you can see here, this is a scout X-ray of the implantation. The patient has this insular implant that goes along the insula after the sylvian fissure has been split, but this patient also has an interrogation of other areas of the brain, including this large 64 grid electrode and then a strip electrode. We've also performed a number of SEEG implantations. So as I mentioned previously, 17 of our 50 patients with SEEG implants had their insula sampled. And this, compared to the Cleveland Clinic experience that I spoke about previously, is actually much less. There are some centers in pediatric and adult centers, but mostly adult centers that are sampling the insula much more than we are. So these are just some illustrative examples that I captured of our patients at Nicholas Children's Hospital who have underwent SEEG implants. So over the years, as I mentioned, we've performed 17 such SEEG surgeries that has sampled the insula, and that comprises of approximately 34% of all of our SEEG cases. So we here at Nicholas Children's Hospital use a combination of different SEEG techniques that I previously spoken about, including the orthogonal technique, the oblique technique, and then coronal and parasagittal oriented oblique techniques to insert the electrodes. So on the top row, you see this is a case of a 15-year-old girl who had SEEG electrodes inserted, and through this anterior coronal oblique technique. So you can see this electrode here, best appreciated on coronal views of an electrode that kind of inserted into the brain through the frontal cortex. And it basically, you can see, if you can imagine the insula like this was a sheath-shaped structure. There's multiple contacts along the insula that is able to capture insular activity. This is another case that was managed at our hospital recently. It's a 5-year-old girl who also has a couple of these coronally oriented anterior oblique electrodes, but also some of these orthogonally inserted SEEG electrodes that goes through the temporal cortex and with the depth electrode near the insula. And you can see here, she has also gone some strip electrodes inserted through a burr hole in order to further sample the surface of the frontal and frontal operculum. This, This is an example of these are a couple of examples of SEEG electrodes inserted through this posterior parasagittal oblique technique. And basically, you can see here, there's this very long electrode being inserted. You can best appreciate that on this axial view or the sagittal view through a occipital entry point. And then with this patient here, a couple of electrodes inserted from an occipital entry point to sample areas of the insula. And additionally, they have these multiple frontal and temporal orthogonally inserted electrodes that go through the frontal and temporal operculum that end up close to the insula that then sample the origins of the seizures and further allows us to understand the propagation of the seizures from one structure to the other. So as I mentioned previously, since the insula is C-shaped, these long electrodes allow us the opportunity of having many contacts over the insula, therefore capturing ictal onset and also seizure propagation. So with this understanding of insular sampling, you may want to know, okay, how many of our patients end up having positive insular sampling and whether there's been any kind of predictors of positive insular sampling. So this is some of our preliminary data looking at 15 years of experience at Nicholas Children's Hospital. You can see here that in total, quite a significant number of patients who underwent sampling of the insula actually yielded positive sampling. So 36% of patients who underwent some type of phase 2 evaluation, so either through a craniotomy or SEEG electrode insertion, of the insula actually yielded positive sampling that led to us either performing an insular resection or an MR-guided lit and ablation of the insula. As you can see here, quite a high number of patients who had their insula sampled through subdural electrodes and craniotomy implants had positive insular sampling. So 41% of all patients sampled actually had seizures either involving or directly coming from the insula. That number is a little bit lower in SEEG implants, and I think that's because we are more liberal in inserting SEEG electrodes into the insula because it is something that's not very difficult to do. The hemorrhage rates and the complication rates of even these deep insular electrodes are relatively low, and it does not involve such a time-consuming and possibly complicated experience of splitting the fissure with an open surgery. So with the SEEG cohort, approximately 24% of our patients who underwent some type of insular sampling had a positive insula sampling that led to either ablation or another surgery. This was underpowered for statistical significance. However, you can see that there's a trend here. There's more patients who yield positive insular sampling through the craniotomy approach versus the SEEG insular sampling approach. And as you can see here, this is a calculation of our trend in positive insular sampling over the years. As you can see with the red, those are patients who we've sampled the insula for, but did not yield any kind of positive insular involvement of the seizure. And the blue are patients that we have performed insular sampling for, either through the craniotomy approach or the SEEG approach, that did yield some type of involvement of the insula in the epilepsy. And as you can see here, over the years, the number and proportion, the number of positive insular sampling has not significantly changed, but we have done more and more and progressively more and more insular samplings over the period of time. So I think we've been much less hesitant to sample the insula in recent years, and especially as we understand more about insular semiologies, we progress to insular sampling without much hesitancy now, especially as we've introduced the SEEG technique in 2015. And as I've mentioned before, there's multiple different ways of sampling the insula with multiple different contacts through this approach. So we looked at our 66 patients with insular sampling and try to see whether there are common semiology or EEG patterns or imaging that can predict insular seizures or predict positive insular epilepsy sampling. So some of the semiologies that we've seen very frequently come up with patients with insular seizures include this epigastric sensation, that is this rising sensation, or this abdominal discomfort that some patients will elaborate on. They can also have hypersalivation and laryngeal and pharyngeal symptoms that manifest as what they consider throat tightening or an abnormal throat sensation. They may also have autonomic abnormalities, including tachycardia, and then in some cases, facial flushing. So those are our most common semiologies that we see with patients with insular epilepsy. And when we performed statistics logistic regression on the sample, we were not able to identify any specific semiology as a predictor of positive insular sampling. In patients who had insular epilepsy, frequently they'll have a very wide ictal EEG onset, but again, it did not reach statistical significance on regression analysis. When it comes to imaging, we frequently will sample the insula or resect the insula when there is a clear abnormality. So that includes MRI abnormalities, abnormalities on SPECT or on PET. And of this cohort, really the SPECT abnormality was the only one that reached statistical significance in predicting seizure onset from the insula, and specifically of our few patients with SPECT abnormalities in the insula, almost all of them had positive insular sampling and originating with seizures originating from the insula. And that's just from our group of 66 children that we've investigated on over the past, who have had surgeries over the past 15 years. So really, in conclusion, since the early 2000s, our understanding of the anatomy and connectivity of the insula have really increased, and therefore our appreciation of insular and insular opercular seizures have really increased. And due to multiple patterns of insular epilepsy spread, insular epilepsy semiologies will really vary, and sometimes they will mimic frontal epilepsy, frontal onset epilepsy, or temporal onset epilepsy. However, some common insular epilepsy semiologies include somatosensory symptoms like epigastric discomfort, laryngeal spasm or throat abnormality or spasm and discomfort, auditory, aphasic, and olfactory gustatory symptoms. And phase 2 evaluations and interrogation techniques like subdural implantation and SEEG implantation have really allowed us to further our understanding of the insula in epilepsy networks, and allowed us to sample the insula with greater frequency, and with especially with SEEG, with greater frequency, and also with very, very few reported complications in literature. And of course, the comprehensive epilepsy program at Nicklaus Children's Hospital have really started interrogating the insula using phase 2 evaluations or invasive EEG evaluations and monitoring since the early 2000s. And over the years, we've had more and more understanding of insular epilepsy and insular opercular epilepsy, and also started to understand the predictors of possible positive insular sampling. So our time is running out. I did not have the opportunity to discuss seizure outcomes in terms of Engel classification in patients who have surgery for insular epilepsy. I also did not have enough time to talk about complications of insular resections like hemiparesis or dysarthria following insular resections. However, in addition, other postoperative outcomes like neuropsychological changes are still investigative. So I think, these are all different topics that we are starting to understand more and more on, starting to investigate more, and certainly seizure outcomes following frontal, temporal, occipital, insular epilepsy might be a fun topic to talk about in another Grand Rounds lecture. So I really want to thank you for your attention, and thank you for joining me today to talk about this topic. If you have any questions, please feel free to email me.
Good morning, everybody. Today I will be discussing the difficult to manage pituitary tumor. So thank you for joining. I have no disclosures that are relevant to this talk. So about almost 2 years ago now, then when I joined, I got a case. This is one of the cases I got on call. 6-year-old male, business owner, no past medical history with progressively worsening vision over a couple of months, but over the last few weeks gotten worse, especially on the right. No longer really able to do his job quite as well, and he, got the glasses fixed. But went in and saw an ophthalmologist. Noticed that the visual acuity on the right was 2100, which is deteriorating, and on the left was 2030. Got Humphrey visual fields and showed a bitemporal hemianopsia. Since it's a July, we'll go over sort of like the end of the workup a little bit so that some of the younger folk can get caught up to speed on this. So we're thinking, pituitary tumor, something along those lines, and you want to get your endocrine workup. And so what does that entail? You want to get the thyroid, all the thyroid hormones, T4, T3, TSH. Females, you want to check the LH and FSH, males, testosterone. You do want to get a prolactin level. Depending on how that results or what you're thinking, you may get a diluted prolactin level. You want to get growth hormone, IGF-1, ACTH, and cortisol. Also, very important is the ophthalmologic evaluation. So you want the visual acuity. Sometimes they'll comment on papilla edema, a little less important, but very importantly, you do want to get formal visual field testing. I get this tumor, and you can see this sort of like slightly heterogeneous but enhancing mass in the cellar region with some supracellular extension. You see the T2 image all the way on the right here, showing sort of bowing of the optic chiasm, the optic apparatus, which explains his visual symptoms. And so this is sort of your like very juicy tumor. Your indications here are pretty clear, right? His vision is declining, and there's compression of the optic chiasm. So what are you going to do? You're going to operate, right? So your management strategy here really is going to be surgery. And in terms of surgical techniques, we, back in the old days, we were used to do these via microscopic approach, either transcranially or either transsphenoidal through translabial, transseptal, but it's still a microscopic technique. And you can see here on the right-hand side, the limitations of your view in terms of the microscope. Whereas what we use now is mostly the endoscopic endonasal technique. You can see your field of view is just much larger, and you get a lot more better lighting, and you get a lot closer to the structures of the cell and the pituitary gland. And then we won't be focusing too much on this today, but there's also the expanded endonasal approaches, transpterygoid to get to the paracellular regions, and et cetera. So we'll be mentioning that briefly, but not focusing on too much today. So, I'm feeling good about this because I can do the endoscopic approach. Everyone gets trained on that. You've done fellowship and residency and then fellowship on this. And so really this is your perfect case, right? So I did the case went great, worked with my colleague, my ENT colleague. And you can see here, this is a 2-year post-op scan. I actually just saw him in clinic yesterday, and got a gross total resection of the tumor. You can see here the stalk still slightly deviated, leading to his normal gland, but that was preserved. No pituitary dysfunction post-op. His optic chiasm here no longer compressed. Everything came down. Looks great, right? So you're thinking, wow, like at this rate, I'm going to be, you're a skull-based surgeon extraordinaire. But the truth is that expectation is not really the same thing as reality. So here's, beautiful beach in Rio, and you're expecting to see that when you go on vacation, but really you're going to run into situations that you're not expecting, that you really have to be prepared for. So the focus of today's talk is not your sort of standard pituitary tumor that makes you look like a great surgeon and makes you feel great about yourself, but these are the tumors that are really sort of tough to handle. That's what I want to focus on today. So something, actually, I'm not sure if it was exactly this case here on the right, but it was something similar. A couple of weeks thereafter, came through the ER, and as soon as I saw the images, I sort of assumed it was a giant prolactinoma. The residents called me, they're like, well, we're going to put the case and we're ready to go. And I was just like, wait. And you're sort of hoping that you don't have to operate on a case like this, right? This is a very tough case. But, you have to be able to sort of manage these tumors if you're going to be focusing on a skull-based practice. So those are the sort of tumors I'm going to focus on today, sort of the more difficult tumors. And so our objectives are going to be really, we talked about some of the indications for surgery, and we'll talk about the difficult non-functioning pituitary adenomas and how sort of the endoscopic endonasal approach allows us to give us some tricks in our bag to be able to manage these. And then we'll go a little bit into the functioning pituitary adenomas as well. We'll talk about growth hormone secreting tumors, talk a little bit about Cushing's disease, and then I'll mention briefly towards the end about the medication refractory prolactinomas, which are the ones that at some point you may need to do surgery for. Along the way, we'll sort of talk about some of these surgical tricks and some role of adjuvant therapies, be it with medication or radiation. Okay. So what are our indications for surgery? If you have a functional tumor that is not going to be responsive to medical therapy, growth hormone, ACTH, or prolactin, that's an indication. And also, there are there's plenty of evidence now to show that things like growth hormone secreting tumors are really best treated. Are best treated with surgery. So. Another reason to perform surgery for these is mass effect, mostly vision, and this could be just direct mass effect or due to an acute situation such as an apoplexy. Okay. Aggressive or growing tumors are also tumors that you may have to at some point handle both with surgery as well as adjuvant therapy. Now, the incidentally found tumors, what do you do with those, right? So it's pretty clear cut that if you have an incidentally found tumor that's not causing any mass effect without any hormone dysfunction, you can observe this, right? And you can just watch it. You make sure to get all the endocrine panel. You make sure to get an ophthalmologic evaluation if you have any concerns or if you just want to get a baseline test, but you don't really need to operate on this right away. Then you have the tumors that do have hormone dysfunction. They're not the functional tumors, but they're causing hormone dysfunction by mass effect. And, the question is, do you operate on those? It's a little bit more controversial, but there is evidence to show that actually the chance of hormone recovery isn't great. It's about 50%, less than 50% or so. So, even those sometimes, if they're not really causing too much mass effect, but you just have some, say thyroid hormone dysfunction, you can continue to observe. A little bit more controversial. There are certain people who will advocate for resection of these. And then also, age is going to be an important consideration. You have to think about, the patient's medical conditions and anything of that, all that sort. Okay. So we're going to talk briefly about each of these situations where the advances in the endoscopic and nasal approach actually gives us a lot of benefit. Okay, so through the extracapsular dissection, that's really going to allow us to get around tumors nicely, try to preserve the function of the normal pituitary gland as much as possible. Also gives us access for paracellular tumors and tumors that have cavernous sinus invasion. Some giant tumors can also be managed with the endoscopic approach really nicely. Subarachnoid extension, third ventricular extension, and recurrent disease, all are situations in which the endoscopic approach actually gives us a little bit of benefit. So first, extracapsular dissection. You see this tumor here. It's actually, this was a bit of a firmer tumor. And there's, different ways to do this. I think initially when we start doing pituitary surgery, there's this thought of, okay, just work from inside out until you get the whole tumor out, which you can do, but that becomes problematic because oftentimes what you'll do is you'll be debulking tumor, and what you'll notice is all of a sudden you've gone through normal gland, and now you're just, at the back of the dorsum sella, and then you're not preserving function, which is a problem. So you can do that, but really sort of the more advanced technique is to try to get around the pseudocapsule if you can, and try to do a true extracapsular dissection. Now, that's not to say you can't get in there and debulk a little bit, right? Because you're not gonna have room initially, so you may have to debulk a little bit, which is fine. But then at some point you should really try to establish on either side, whichever side, oftentimes people will say you go to the side where you don't think that the normal gland is, and you sort of start working around there and see if you can establish yourself a pseudocapsule. so that you can work around that. And the endoscopic approach really allows us to get better visualization and better lighting to create, to really define. You can see here, you know, there's this relatively avascular tumor. This is a pretty fibrous tumor, which you can get around. And you can see here that this is more normal gland material. And the extracapsular dissection allows you to really preserve the function that way. One technique that Danny Prevedello actually published about is, you know, using a Q-tip as a method of dissection of the pseudocapsule. You know, this is a two-handed technique. I know that's something that we talk about a lot in pituitary surgery. It is important to be able to actually have a two-handed technique and two surgeons, so you're really using a four-handed technique. So the Q-tip sort of assists you in this technique to really give you a little bit of counter traction as you're working around these tumors. And it really allows you to sort of define the pseudocapsule quite nicely. It's very inexpensive. It's firm, so it gives you a little bit more tension. And you're not gonna, you know, you're not using an instrument that actually is gonna perforate, so that really allows you to respect the pseudocapsule. So that's one technique that you can sort of use to help yourself as you're working. Okay. Then paracellular extension. So how does the endoscopic endonasal approach help us with that? You can see here, you know, this is sort of like where the sella is sort of where you would be limited if you're just using a microscopic technique, and where the endoscope allows us is to really travel further out laterally as we extend into the paracellular spaces, into the cavernous sinus. You can see the tumor here in the cavernous sinus and sort of wrapping around the carotid. And you can, some of these tumors can be sort of chased into the cavernous sinus to some degree, especially if it's just invading the medial wall, in order to be able to resect, to get a maximal resection. Now, in order to do that, you have to be very comfortable, you know, really knowing where your carotid artery is going to be within the cavernous sinus. And I think this picture here is just showing the importance of the Doppler probe. You know, we don't often have that at Jackson, Maine. They can't always find the endoscopic one. I think that's quite an issue. If you're going to be doing these types of cases, we really should be working with the Doppler probe. You should be able to trace out the carotid the entire way in order to know exactly where to make your dural opening, where it's safe. And certainly if you're going to do any resection of the medial wall of the cavernous sinus, then knowing exactly where you are is very important. Also, this sort of highlights the importance, you know, oftentimes if you're just doing your small pituitary or even a macroadenoma, you're going to limit your opening just to the sella. But if you're doing any tumor that has any paracellular extension, you have to have a wide bony opening. This is sort of, you know, all roads lead to Pittsburgh when it comes to pituitary surgery. And if you go to the Pittsburgh course, one of the main things that they'll teach you is every opening should be the same, everything should look the same, and it should be a wide opening. If you're just doing a small pituitary, you might want to reconsider that. But if you're doing anything that's more extensive, you really should be doing a wide opening of the bone overlying the carotid and overlying the cavernous sinus. And then you could be able to trace out the exact course of the carotid using the microdoppler probe. We'll talk a little bit today about the NOSP classification. So this is just a classification scheme that we use in skull-based surgery. There are many schemes. This is just one of them. But essentially, it's to determine the degree of cavernous sinus invasion. And you can see here, it ranges from a grade 0, where the tumor is entirely within the sella and is not actually abutting or is not near the cavernous sinus, all the way through grade 1, where grade 1 and grade 2 abut, but don't necessarily invade into the cavernous sinus, whereas grades 3 and 4 are going to be more invasive, and 3A being invasive into the superior component of the cavernous sinus, 3B into the inferior component, and 4 just circumferential around the carotid artery. And that this really sort of allows, it's a grading scheme that allows us to characterize tumors by their invasiveness into the cavernous sinus. And then there have been a lot of studies done to determine, you know, what does that mean in terms of extent of resection. And it was actually found that resection rates do highly correlate with degree of invasion of the cavernous sinus. Again, a study out of Pittsburgh here showing that, you know, for the lower grade NOSP 1 and 2 tumors, you're able to get gross total resection, whereas that decreases. And we're talking here on the NOSP 4 grades, you know, you're talking about tumors that are really invading the lateral wall of the cavernous sinus. Then you're talking about involvement of the cranial nerves and leaving the patient possibly with an ophthalmoplegia, and also possibly more possibly carotid injury or invasion into the wall of the carotid. and that's going to be causing you more problems. So that's, perhaps those are the tumors that you don't want to be going for broke. You really want to be leaving tumor behind to either go through a different approach if you really have to, if it's, in a functioning tumor, or, things like radiosurgery really become very important here, because it can be an adjuvant treatment that really has very nice tumor control and prevents some of these really well-known complications. Now, as particularly Dr. Juan Fernandez, who's at Stanford now, he's done extensive work about the invasion into the medial wall of the cavernous sinus, the anatomy of the different ligaments within the cavernous sinus, and how to resect that. And as he is resecting more and more of the medial wall of the cavernous sinus, what they're figuring out is that the NOSP grading scale, and this is not published data yet, but he's mentioned this in several talks, is that the NOSP grading scale doesn't really hold up for, I don't know if I lost you guys, sorry. The NOSP grading scale doesn't really hold up for the functional tumors, that in fact, some of the functional tumors that are considered NOSP, 1 and 2 actually do have invasion. And so that's going to be something that pans out a little bit differently. Okay. Then in terms of giant tumors, this is another area where the endoscopic approach can be really beneficial. These tumors can be very tricky, and people will describe combined approaches, and then there's a lot of talk about what the timing is, right? Because if you do an approach from below and you leave some tumor behind, very frequently people will deteriorate in the middle of the night, they'll hemorrhage into it. That's a known fact. I think the timing of the approach, if you're gonna do combined, it's probably more appropriate to do it together as opposed to sort of staging it, because oftentimes it can lead to tumoral hemorrhage. But invasion to the medial wall of the cavernous sinus did not limit the degree of removal for giant adenomas using the endoscope. So it really just gives us access to taking very large tumors out, even through the nose. So one of the things that Dr. Pervadello from Ohio State, who does also quite a large number of these, noticed is that in his study, the giant tumors, the tumor size, not only maximal diameter, but just tumor volume, was predictive of postoperative DI. So, one of the tricks, another trick sort of in the surgery for these giant tumors could be to put an inlay of either, Duragen or any sort of cellular matrix that you're going to actually use to tent up the normal pituitary gland that hopefully you've preserved and left behind. The idea being that the stalk, if you have these giant tumors and all of a sudden, you have a sort of a sagging of the stalk, that can lead to worse DI postoperatively. So that's something to consider, whether or not tenting up the actual normal gland and the stalk would be beneficial. So that's another trick in pituitary surgery that for these giant tumors that can be beneficial in terms of getting a resection. Next, these tumors can have subarachnoid invasion, okay? And you can approach this through the endoscopic approach. And for the tumors that do have subarachnoid invasion, these are a little bit different. They're sort of what we call like the aberrant adenomas, because they really do behave like invasive tumors. And this is where resection with the four-handed technique is really critical. I know when we talk about pituitary surgery, we talk about just using sort of ring curettes. That's not the way to do these tumors. I think, when the patients, some of these guys that are at Pittsburgh and Stanford at the really high volume centers, they'll tell you that, they'll have one ring curette in their set, and that's it. The rest of their instruments are, they have lots of scissors. You have to have scissors both to the right and left, up and scissors that can move around oftentimes can be beneficial. And then they have these endoscopic, what they're essentially like rodent microdissectors. So it's very important that you are comfortable with your instruments and that you actually have instruments where you can do true microsurgery, even though you're doing this through the endoscopic approach. We'll talk a little bit later more about the resection of the medial wall of the cavernous sinus, and the Mcleve knife that Juan Fernandez and the Pittsburgh guys sort of created is very critical for the opening of the medial of the cavernous sinus in general, and doing that safely. So I think there's sort of a misunderstanding that the ring curettes will get you all of the dissectors that you need for pituitary surgery. But when you're talking about these complex and invasive tumors, you really want to have finer, and you really want to have the rodent type instruments. You know, you're oftentimes dissecting, you know, the big arteries, certainly, but also you can have these small perforators that you're dissecting that you do need to preserve, that you need to be able to get to. The other instrument that can become beneficial in more fibrous tumors is having a sonopet available. You know, this is more common if you have if you're using this for resection of endoscopic resection of meningiomas, but certainly there are some pituitary tumors that can be quite fibrous, for which you will need a sonopet or, you know, any sort of aspirator that allows you to sort of get through, because suction is not going to really work for you. And then when you get to the dissection of around the capsule, you really do need micro instruments. Okay. Tumors with third ventricular extension. These tumors also, this is back to the Pittsburgh study, they also looked at whether third ventricular extension did affect the degree of resection. It did not. So in other words, the endoscopic approach is successful for this. And actually, you know, these tumors can be soft and they sort of fall down at you. And one thing that that Bill Caldwell talks about that's very useful is that you can actually, if these tumors are soft and they're sort of like giving, you can actually ask, either do jugular compression, or you can ask the anesthesia to give you a Valsalva maneuver and see what the tumor gives you. And actually sequentially doing Valsalva maneuver while you're trying to resect the tumor sort of dissects and falls at you a little bit. So don't, you know, don't hesitate to take advantage of what you can in terms of trying to get these tumors to fall down and really give at you. And then obviously once you do have that resection, you have a gorgeous view into the third ventricle, oftentimes into bilateral foramina of Monroe. So we've talked about how the endoscopic approach really gives us access sort of everywhere, right? You can go up, you can go sideways, you can get giant tumors, you can get tumors that are into the subarachnoid space. So what's the endoscopic approach really not good at? You know, they wanted to identify, it's got to have some limitation, right? So what are the limitations? So essentially, if you have multilobular giant cell adenomas, those are sort of tough. And especially in the anterior compartment of the cavernous sinus, gives you a little bit of a blind spot. So that was found to statistically decrease the resection rates, as well as extension into the middle fossa. And that's clear, right? If you have a large extension into the middle fossa, you probably want to come through a transcranial route. And I think part of the trick in sort of becoming sort of expert in these difficult pituitary tumors is really recognizing what approach is appropriate, and also not being afraid to combine approaches. The repair and cerebrospinal fluid leak, you can imagine for that tumor, you know, tumors going into the third ventricle with these high flow leaks, that the repair was sort of quite of an issue. And I think in high volume centers, you know, you get pretty low rates of CSF leak, and this decreased dramatically with the invention of the nasoseptal flap. Which we now use routinely for you know, the large reconstructions. You don't, again, this is not something that you're going to be using for your routine pituitaries. And I know certainly our group here uses it very judiciously, but the nasoseptal flap is a very, very useful technique in reconstruction. And there's different things you can sort of do to check the viability of your nasoseptal flap. You know, you can check with ICG to make sure that it's, you know, that your pedicle is still vascularized, and obviously just by looking at it. But oftentimes what you can do is do the surgery first and then go back and then raise the nasoseptal flap at the end as well. Sometimes that can help preserve the viability of the flap so that you're not manipulating it as you enter and exit the nose. Vascular injury, obviously everybody fears this, and certainly as you start in your journey of more difficult tumors, and having to drill out the carotid routinely, this becomes an issue. The ICA injury rate for their group was actually pretty low, and I think this is even decreased over time. So it's really just a matter of you know, experience, and there is a learning curve. I wouldn't necessarily do a giant tumor into the third ventricle with subarachnoid extension as your first case, but you know, there's a learning curve in terms of how experienced you are with these tumors. So I'm going to shift gears a little bit here. We talked about these giant tumors that are difficult to manage and certain tricks that can help you. We're going to shift gears now for the functioning tumors. Those were non-functioning tumors. And in functioning tumors, we have a different set of difficulties, not necessarily in their size, but sort of in their in how difficult they are to resect. So our primary indications for surgery in terms of functioning tumors are acromegaly and Cushing's, right? Because that has known impact in terms of life, mortality, and function. And then secondary indications would be prolactinomas that are failing medical therapy or are causing problems with energy, fatigue, sex drive, patients trying to get pregnant, whatever it might be, that might lead you to say, all right, well, we've maximized or we've reached our limit of what we can do with the medical therapy and we need to part to surgery. So first we'll talk about the growth hormone in acromegaly. So as we know, growth hormone is secreted by the pituitary gland and acts on the liver and secretes IGF-1. And it acts throughout the body, in skeletal development and body composition, gain of muscle and loss of fat. It's known to have important impacts in the quality of life, cognition, and also cardiovascular function. So it's clear that if you are going to have excess of this, some of these things are going to be impacted. In the setting of acromegaly, you have a growth hormone secreting adenoma, which is going to secrete excess amounts of growth hormone. And then you're going to get high doses of insulin like growth factor, which are going to act on these end organs and can cause problems, right? So how is the diagnosis made? So measurement of IGF-1 levels is the best. Random growth hormone levels will be elevated, but there's not, a particular level that has been used as a cutoff. So it's not quite as useful. What is more useful is what you can do is you can confirm by giving a glucose load. Once you give a glucose load, you should really have suppression of growth hormone to less than 1 nanograms per milliliter. And if you don't have that suppression with an oral glucose load, then you're sort of then you can diagnose an issue that way, and that can lead to you getting imaging. What are the clinical manifestations of acromegaly? So you have debilitating facial and physical changes like the frontal bossing, the macrognathia. You can have arthritis, diabetes, impaired quality of life. In terms of respiratory disorders, it's usually in the form of sleep apnea. Their nasal passages are very large and obstructive. In fact, sometimes doing endoscopic cases in these patients can be tricky because their nasal passages are so sort of like hypertrophied. Their bone is going to be very thick, right? So you're going to be drilling for quite a while. So as you can see, there's just many end organs that can get affected from elevated levels of growth hormone and IGF-1 circulating. What do we consider disease control? Essentially, you need to have both normal insulin like growth factor for levels for age and sex. And you want to also see that you can get suppression of growth hormone levels to less than 1 after a glucose load, or a random growth hormone value less than 2.5 at 3 months post-op, right? So you're going to check that in a delayed fashion, right? So what are our options? Our options for surgery is going to be our first choice. One, if you have a macroadenoma that's causing any sort of mass effect, you're going to get improvement in that. But most importantly, I think in terms of the problems with that the growth hormone, that elevated growth hormone can lead to issues, in end organs in the bloodstream. What you want is a rapid and you want a long-standing cure, right? Obviously, tissue diagnosis is important. We send that off for the pathologist. We do look at certain levels to see whether or not, the Ki-67 might be elevated, to see, recurrence rates. But most importantly, you want to really just get long-standing cure in terms of a hormonal component. Interestingly, almost a third of growth hormone secreting tumors won't be cured after the initial surgery, right? And so then we've looked at repeat surgery, and I'll talk a little bit more about that in a little bit, but we found out that actually repeat surgery, in the second go around, doesn't really improve your outcomes. So you really want to get these out. You want to be very aggressive in your first go around because that's really your best bet. There are medical options, medical therapy for cases that don't go into remission after surgery. And then, radiation therapy really as an adjuvant. We really want, this is not like a primary treatment for growth hormone secreting tumors, but really it's more of like if you have residual tumor that you think repeat surgery won't help you with, or that you can't get to, or, now you've done surgery and you have a medical and you have adjuvant medical therapy, and both of those things aren't controlling. Well, radiation therapy does play a role. And you can see that down here, whereas, about 60% tumor control rate with just surgery alone, you can get that up to about 80% if you sort of combine that with both radiosurgery and medication. I'm not going to go too deep into the actual how the mechanism of action of each of these drugs, but there are different drug options for growth hormone secreting tumors. Somatostatin receptor ligands like octreotide is the one that we know that everybody talks about. Dopamine agonists can be used, and human growth hormone receptor antagonists can be used. Some of these medications can have pretty debilitating side effects, and this can be one of the limitations. All right, so that includes GI symptoms, hyperglycemia, and hepatotoxicity, et cetera, that may limit your ability to continue medical therapy. In terms of radiation, so oftentimes, we talk about whether it's large field radiation or SRS. Factors that are going to favor SRS is if it's going to be stuck to an artery or a nerve in the cavernous sinus, we want sort of a more focal radiation. The lateral part of the cavernous sinus, also where the nerves are. And then if you have regrowth that you really can't get to surgically, it's going to be a small amount, right? So you're going to have a small volume, which you can actually, SRS might be more efficacious for than a large field sort of fractionated radiotherapy. Importantly, and this varies, usually most reports will tell you around 25% of times you can lose hormone function after radiation, but that can vary from 20 to 40%. So here is just a study done that looking at the radiosurgery for growth hormone secreting adenomas. One thing that's important when you do have a functional adenoma, the median margin dose, you're using a pretty high dose. 20 grays is quite a high dose for a benign pathology. And the reason for that is that obviously it's a secreting tumor and you want to get good control. And 50% had biochemical remission at a median of 36 months. And importantly, I think this is, very, very important. When you're doing SRS, what they looked at is what are the predictors of success. And two things. One of them was IGF-1 levels less than 2.25 times the upper limit of normal. And one thing that is important is the absence of pituitary suppressive medications at the time of SRS. So we will actually stop these medications if you're going to plan on doing SRS, right? Because that correlates with biochemical remission. And you can stop that about 3 to 4 weeks beforehand. And then again, incidence of a new anterior pituitary deficit in this study was 10% at 2 years and 33% at 5 years. So you can see that that's where you sort of get that range of anywhere between 10 up to 40% I've seen in certain papers. So after surgery, what about how good are we at getting biochemical remission? So again, they looked at this at Pittsburgh, and they looked at for acromegaly patients, endoscopic and nasal approach can lead to disease control for most people, right? So you're talking about around anywhere between, 45 to about 75 to 80%, all right? That's 75%. That increases to about 80% in the setting of endoscopic with either SRS or medical management. So surgery alone is a little bit less, and this is sort of very, this is sort of proven in different studies. The Hearty Staging is just another, similar to like the Knopf's grading scale, is sort of tells you invasiveness. It takes into consideration invasiveness and size. And you sort of see here just sort of what your remission rates can be. And as you would expect, in terms of the more invasive tumors that you get, which are these NOSP grades 3 and 4, or the Hearty stage C and D, you're going to get lower remission rates. And you can still improve those remission rates a little bit by adding SRS and medical therapy, but it's still not going to be perfect, right? You're still not quite there. And this can be a problem with the hormone, the secreting tumors. So if you're only getting about 50 or 60% remission rate after surgery, and this was a meta-analysis done out of Ted Schwartz group at Cornell, you're really only getting to about 55 to 60%, right? And your first go around is really your best bet, like I mentioned. The reoperation group, we did not note that you got any improvement in biochemical remission rates after the second surgery. Microadenomas did have a trend toward higher likelihood of hormonal control. That makes sense, right, in terms of invasiveness. And then disease control was also significantly associated with older age, absence of cavernous sinus invasion, as you would expect, and lower pre-op rates of growth hormone and IGF-1 levels, right, and smaller tumor size. So we can certainly get some biochemical remission with surgery alone, especially in the tumors that are sort of limited in their invasiveness. We can certainly get improvement of remission rates, biochemical remission rates, when we add SRS and medical therapy. But can we do better just with surgery, right? Because if we're saying that our first surgery is our best bet, like how can we be most aggressive in our first surgery and be safe? So this was initially studied, well, Dr. Oldfield did tremendous work in looking at growth hormone secreting tumors and invasion into the cavernous sinus. This was also followed by the Japanese group. A Japanese group in about 2013, 2014, they were already doing resection of the medial wall of the cavernous sinus. They just had not described the technique. So Juan Fernandez Miranda out of Pittsburgh and now in Stanford, studied the anatomy of the cavernous sinus from the endoscopic approach very extensively and did very beautiful anatomic studies describing each of the ligaments that sort of connect the carotid artery into the medial wall of the cavernous sinus, because in that way, in knowing the connections, we know what we have to cut in order to release the medial wall of the cavernous sinus. So you can see here, as we know, there's the periosteal layer of dura and the meningeal layer of dura, and the cavernous sinus is really just like any other sinus, a division between these two layers, right? So you can see here, you have, this is already in the cavernous sinus, right? So this is already within the medial wall of the cavernous sinus. The medial wall would be right here. And that's where the ligaments are. And you're gonna have a few ligaments that he describes. Some of them are more robust. The most robust of these ligaments is the carotidoclinoidal ligament. There's the inferior interclinoidal ligament. Interclinoidal ligament. And then there's going to be also the inferior paracellular ligament and the posterior paracellular ligament. And we'll see pictures of those a little bit later. And he describes, so this is the outer layer of dura, inner layer of dura. And as these two separate going laterally into the cavernous sinus, that creates the space which sort of where the carotid artery resides, and that you have blood, but it also gives you a window here in the inferior border to get into the cavernous sinus, and that's sort of where you enter, right? So the medial wall is going to be here, and the ligaments are going to be attaching to the carotid artery. These are the paracellular ligaments, right? So he describes a step-by-step approach of how you can actually resect the medial wall, okay? This is what I was talking about. This is the space you sort of want to get into, right, as the dural leaflets separate. And then you can use that Mcleve knife that I was saying, which is a blunt probe. It has a blunt end, but the top of it cuts. I think I have a picture of it at some point. And once you make your entry here, you can start making your cuts superiorly to cut out this medial wall here. So these are your cuts. So this is your inferior paracellular ligament, which is the first one, and it sort of attaches the medial wall of the cavernous sinus to the anterior wall of the cavernous sinus. So you have to make this cut first in order to get access to the medial wall and release it. And just deep to that, you often find the inferior hypophyseal artery. And you want to actually identify the inferior hypophyseal artery before you avulse it from the carotid, because that can lead to devastating injuries. and actually coagulate it and cut it. So you're going to have to cut the inferior hypophyseal artery, and that's often found just deep to the inferior paracellular ligament. Okay, and then you're going to carry your dissection superiorly. Okay, and as you carry your dissection superiorly, what marks sort of the roof of the cavernous sinus from the endoscopic approach is going to be your carotidoclinoidal ligament and your medial clinoid. I'm sorry, your posterior clinoid. So you extend your cut superiorly until you reach that, and you actually have to cut the carotidoclinoidal ligament in its entirety. And again, like I said, this is the most robust one. It can be one small ligament, or it can be multiple layers of ligament, and you cut that pretty clearly until you reach the interclinoidal ligament. And the interclinoidal ligament is between the anterior and the posterior clinoid. And that is when you reach the interclinoidal ligament is actually when you know that you are all the way through your carotidoclinoidal ligament. And that's a very important landmark, because until you release that, you really can't get rid of your entire medial wall. Okay. So, again, this is actually after you've resected it. And this is just showing that, once you've gone all the way through your, carotidoclinoidal ligament, the last thing you're going to reach is your interclinoidal ligament, again, between the posterior clinoid and the anterior clinoid here. And that's how you've actually released the medial wall entirely, by cutting through the carotidoclinoidal ligament and resect it that way. So this seems like a pretty intense procedure. Why would you do this? The reason is that they actually would send off the medial wall of the cavernous sinus, and you have the pathologist look at that, and they found that 86% had histologically confirmed tumor. That's quite a large amount, right? So I think in some tumors where we think that we're getting all the tumor out, in fact, there's still tumor in the medial wall of the cavernous sinus, and that can lead to recurrence. That in the setting of a functional tumor can be very problematic. So, when you're talking about a growth hormone secreting tumor, and you think there's going to be invasion of the medial wall of the cavernous sinus, you really should be considering taking these out. What Dr. Fernandez is sort of advocating is perhaps you should be taking this out more often than not, because as you can see, there's a high rate of invasion, right? So when he did this medial wall resection for 50 tumors, he did not have any carotid artery injuries. Obviously, this takes quite a bit of experience. So it's not something that you're going to do without any sort of, skull-based training. Some patients did develop a diplopia that resolved completely at 3 months follow-up. This can be a combination of both. Obviously, you are manipulating the sixth nerve. You can use monitoring, to sort of not identify the sixth nerve, but to confirm where it is where you think it is. But also the use of gel foam, right? You're working in the cavernous sinus. You have to use Surgiflow to control your bleeding. And sometimes that can lead to a little bit of swelling, which can lead to a transient sixth nerve palsy. So the initial biochemical remission was 98%, which is pretty significant. And you can see here that this was just when they sent it off for the pathology, that there was positive staining there. The Stanford study showed that 77% by histological studies and 90% just by looking at it intraoperatively. This is Dr. Fernandez doing these cases up at Stanford now that he's there. And that's really quite different than what we used to think, in terms of the previous study sort of showed that it was about 30% of the time. So this is quite an overwhelming majority of the tumors that are invading that wall. In terms of the short-term biochemical remission in acromegaly, the Stanford experience is that the growth hormone level dropped to 1.01 postoperatively in the immediate postoperative period, which is, pretty good prognosis. And that's improved even from previous studies. And these are a highly experienced group at UVA, and they got their growth hormone level in the immediate postoperative period to about 2.20. And this is already an improvement. And he attributes this to that resection of that medial wall. Long-term biochemical remission he describes 91% long-term remission at 3 to 12-month follow-up without any medication or radiation. And then that increases, again, remember, we always said that with adjuvant therapy, which is SRS and or medication, you usually get an increase in the biochemical remission. And we really see that here. So, I mean, these numbers are very impressive. So, you know, it's something to consider. Obviously, it takes a high level of expertise to be able to do medial cavernous wall resection, but it should be something that's considered in some of these really tough tumors. This is that knife that I was talking about, the Mcleve knife. It's essentially a blunt probe, but this is a very sharp end, and it allows you to get in between the layers of the cavernous sinus and really initiate your resection. And you can do this such that you're staying off of the carotid, and yet you're able to resect that medial wall. So in terms of resection of the medial wall, I think it's what we're seeing is that the growth hormones, adenomas are invading them much more often than what we previously thought and what was previously reported. So about 75 to 90% as opposed to 30%, which is what we thought. It dramatically improves remission rates. You know, we talked about 50 to 60% and even sometimes lower in the sort of more invasive tumors as per the Hearty and the NOSP criteria to what we're saying now, more than 90%. That's pretty dramatic, but obviously we need longer follow-up, right? And it can be safe in experienced hands, but I think ultimately, I think it shows that acromegaly patients really should be treated at highly experienced pituitary centers, because you're not really doing patients any favors by, you know, doing not a great surgery the first time around, because I think what we saw in that meta-analysis that Ted Schwartz did is that that first time around is really your best bet, and that second time surgery doesn't really help you too much. So that's sort of acromegaly, growth hormone secreting tumors, resection of the medial wall of the cavernous sinus. I'm gonna move over to Cushing syndrome a bit. So I think we still have some more time. So Cushing syndrome essentially is when you have supraphysiologic levels of systemic circulating cortisol, which presents with a constellation of symptoms, right? So in the normal patient, we have the hypothalamus secreting CRH, which then acts on the pituitary gland to secrete ACTH, which then acts on the adrenal gland to secrete cortisol. And this has a negative feedback loop, both on the pituitary gland and the hypothalamus, right? So that keeps things in check. In Cushing's disease, you're going to have excess levels of ACTH being secreted possibly by a pituitary adenoma, and that acts on the adrenal gland to then elevate the level of cortisol in the system systemically. Cushing's syndrome is a clinical manifestation of this. So patients, you know, I think most people know, we don't have to go into too much detail about this, but the moon faces, buffalo hump, easy bruising, these are sort of the more physical manifestations. But, you know, again, in terms of cardiovascular disease and sort of mortality, it does lead to decreased mortality because of effects that it can have on poor wound healing, infection, hypertension, diabetes. And so it can really affect health in a pretty negatively impact health in a pretty significant manner. Cushing's disease is when you have a pituitary tumor producing ACTH that causes the adrenal gland to oversecrete cortisol. And it's the most common etiology of endogenous Cushing's syndrome. So it's usually a tumor of the pituitary gland. These are the results of somatic mutations. There's really not much you can do to prevent this from happening, right? So it's not too common, more common in women, usually occurs in adulthood, although you can see this in children, counts for about 10 to 15% of all pituitary tumors. And a lot of these, more than 50%, are smaller than 5 millimeters on presentation. So that in and of itself makes it difficult, right? The diagnosis of it is difficult. Some of them can be larger. They can extend into the suprasellar compartment. And again, the Cushing disease-associated mortality is known as a known fact with increased cardiovascular risk of death. Even after biochemical remission, that risk of death remains for about up to 5 years in some studies. So how do we diagnose Cushing syndrome? You can do a 24-hour urinary cortisol, low-dose dexamethasone suppression test, and that could be either 1 milligram or 2 milligrams over 2 days. Pretty good accuracy for Cushing syndrome. And that normally leads to suppression of cortisol to 1.8 micrograms. And the difference here is that pituitary tumors are not going to suppress with this, right? And then you have the late night salivary cortisol test, which is actually very accurate for Cushing syndrome. It's pretty specific there. So, you know, once you have Cushing's disease, differentiating between pituitary and other sources can be different. You can have other sources of cortisol, and that could be either iatrogenic, right? You could be giving medications, or, you know, you can have ectopic sources of cortisol and, you know, adrenal. So we talk about Cushing's disease sort of as an ACTH dependent, right? In the setting of an adenoma or an ectopic tumor, or an ACTH independent, where you have adrenal sources, right? And ACTH levels of greater than 10, sometimes, you know, people say 20 as well, can signify an ACTH dependent cause. And then there can be some, you know, genetic causes that can be associated with familial Cushing's. So we talked about some of the initial tests, right? So what are some other tests to differentiate once you've, to differentiate whether or not you have this source coming from the pituitary? So we use the high dose dexamethasone suppression test, and this is an 8 milligram of dexamethasone. Essentially, if it's a pituitary source, it will suppress with the high dose dexamethasone test. And that's going to suppress more than 50% decrease. And if you have a non-pituitary source, you're going to have elevated levels of cortisol independent of the source. And so it will not suppress with the high dose DEXA test, okay? Once you have sort of an idea that you have a pituitary source, then you can look at MRI, right? So you're going to get your imaging, and like I mentioned before, the tumors are going to be frequently small, mean a 5 to 6 millimeter diagnosis. And they're oftentimes about 10 to 20% of the time, you can even have negative MRIs and still have Cushing's disease. And that we'll talk a little bit more about, but that can lead to an entire set of other complications, right? There are certain special sequences that can be helpful, either FLAIR or dynamic imaging, GRASP imaging. And this is where you give contrast, and then you're going to take imaging sequentially over a period of time in order to be able to what it does is, because of the blood flow through the normal gland versus, the tumor uptake, it can be different, and that actually can show up on some of the MRI studies. There are some studies showing that some of these Cushing's disease tumors, these pituitary tumors, can uptake glucose. And so if you tag it, then perhaps a PET study might be useful. This is, not being used routinely, but can be used if you're having trouble differentiating. And like I said, they can, I guess, even up to 50, some studies show even up to 50% of the time, they can have a normal MRI, right? So here's you can see here on the left, this is a 1.5 Tesla MRI, and you don't really see much there, right? That's probably going to be read as a normal study. Whereas here on the right, if you're looking at a 7 Tesla MRI, you can see this small pituitary tumor in the inferior aspect of the cella here on the right. And you may not see that, you might have missed that unless you have really sort of appropriate imaging. And here on the bottom is that FLAIR imaging that I was talking about, and some of these GRASP sequences, where again, the picture here on the left, this may be read as a normal study, whereas here on the right, you can see this microadenoma, and very frequently these will be hypo-intense, will not take up contrast. So that's important to sort of keep in mind as well. One more test that you can do is Vasopressin or Ddavp stimulation test. You can give 10 micrograms of Ddavp, and the cortisol level will rise in Cushing's disease, but not in the pseudo-Cushing state. Okay, and this can be pretty accurate. This was being used, I think, in some of the groups, but in Wisconsin, they were talking about using some of that as well. Finally, if you really don't know what's going on and you want to differentiate further, you want to do this inferior petrosal sinus sampling. And this is, where having a group of like a pituitary center is really important, right? Because you need to have your endovascular team. Not only do they come into play for, vascular injuries, but it's very important to have people who have experience doing inferior petrosal sinus sampling, because the sensitivity and the specificity of this test is really going to change pretty dramatically based off of experience or use, right? This is an old test, okay? And when do we use IPSS? So if you really don't know and you've gotten your MRI, you've gotten advanced imaging, you don't have a tumor that you can find, and you sort of have determined that you have Cushing's disease and you want to localize it a little bit better, then you can do IPSS. And that not only allows you to determine whether or not it's true Cushing's disease, and it also allows you to lateralize to the side of the gland. And to avoid false positive, it must be performed while the patient is hypercortisolemic, and we do stimulate that with CRH, right? So why does this work? So the pituitary gland is going to drain into the cavernous sinus, which is then going to drain into the inferior petrosal sinus bilaterally. And that is so the level of cortisol within the level of ACTH within the inferior petrosal sinus compared to systemically is going to change pretty significantly. And that ratio allows you to really determine whether or not you have a true Cushing's disease. So the technique is you're going to have bilateral venous access, right? And then you're going to bring catheters to both sides into the inferior petrosal sinus. And you're going to take samples both from the periphery as well as from the inferior petrosal sinus. And you're going to do that at baseline, right? And then you're going to do it sequentially over time. And you're going to take both in the periphery as well as in the petrosal sinus, both on the right and left, to sort of be able to determine which side your tumor is really going to be locating to. And then you can have a sort of prolactin as a control group there as well. And you do give CRH. So this is baseline and 0, 3, 5, 10, and 30 minutes after you given CRH in order to get the ACTH stimulation. Okay. So there are some contraindications to IPSS sampling. Obviously, with any invasive procedures, you can have complications. We won't go into this too much further. So when you have Cushing's syndrome and clinical features of Cushing's, this is sort of the algorithm that you want to be thinking. Talked about some of those preliminary tests that tell you, okay, yes, you have Cushing's syndrome. Then you have to look at your ACTH level. If it's suppressed, then you know you have an ACTH independent Cushing's syndrome, and you're thinking of an adrenal source, right? If it's normal and or high ACTH levels, you're talking about an ACTH dependent situation. And you're thinking, okay, is the source either pituitary or an ectopic source, right? And that's where you can go into the other methods that we talked about, which is the high dose dexamethasone test, which should suppress with 8 milligrams of dexamethasone, right? If you do have this situation, you're also going to get your imaging, right? So you're going to get your MRI and your advanced imaging, and you can also give CRH. So if you either through this, you find out that you have an ectopic source of cortisol, you're either going to find a pituitary source, right, which is then you've diagnosed your Cushing's disease, you've gotten to your endpoint. And if you really aren't sure about whether or not the source is ectopic versus a pituitary source, then that's when you sort of go down the line of inferior petrosal sinus sampling to determine, okay? So it's an algorithm. This is a great algorithm if you just want to keep this, keep track of this, put this up somewhere, but this is sort of how you think about how you get to the true diagnosis of a pituitary Cushing's disease. So it's kind of a busy slide, but again, talks about how surgery really is the optimal treatment in terms of Cushing's because of the effects that it can have on mortality. And your best opportunity is going to not only be for cure, but also for preservation of normal pituitary function. First operation being the best go around again. In MRI positive tumors, especially for these microadenomas, pseudocapsular resection has the highest probability of successful resection. And this can be tough, right? Because you're going to go through somewhat normal gland. And so you really have to have experience in order to be able to determine when you're through the normal gland and now you've reached your pseudocapsule, and really work around in a close manner to the pseudocapsule, but staying out of it in order to be able to get the whole tumor out to get endocrine functional improvement, but also preserving your normal gland. So what do you do if you have the MRI negative tumors, which we said some studies will show 10 to 20%, but up to 50% of these tumors can be MRI negative. So you have to sort of explore and see what you're looking at, right? So you can use your inferior petrosal sinus sampling to sort of help you out. That'll help you lateralize the side. And there's different ways to do this. You know, some people will do it by quadrants. Some people will do it in sort of vertical slices. And what you really want to do is explore all of the gland and see if you find abnormal tissue, or if you find something like a pseudocapsular or a microadenoma. Even though it's MRI negative, you can find some tissue that looks like tumor, and you take that out. But it is important to sort of sequentially, and whatever way you do it, just, you know, be very methodical about it so that you're not missing any portions of the gland that you're exploring. So you could do either partial hypophysectomy, right, or complete. Obviously, being panhypopit being the complication of complete hypophysectomy that you have to take into consideration. Once you've done the resection of either your microadenoma or your gland or your partial hypophysectomy, you want to follow your postoperative cortisol and your ACTH. You're going to get a crash usually within 48 hours. You want to follow this closely every couple hours or so. And once they get down to a serum cortisol of about less than 3, they really do get uncomfortable. It takes time for the body to sort of build back up the ability to produce ACTH. So these patients will feel pretty horrible. And at that point, you sort of want to initiate steroid treatment. Some people will initiate steroid treatment just right away because this is a known sort of phenomenon that will occur. Or you can, you know, monitor the levels closely. So what's our remission criteria for these Cushing's disease? Essentially, in initial postoperative remission, you're talking about a nadir cortisol of less than 5 or less than 3, like I talked about during the first 36 to 48 hours of surgery, or an 8 a.m. cortisol less than 5 within the first 2 weeks, right? But that's not enough. The important thing here really is long-term control again. So these are just different categories which we used. You know, this is all just saying that back in the day we used to say, okay, you have a drop in the nadir cortisol, so that's great, success. But now we have very sort of specific, the endocrinologists have very specific categories of how much they want the cortisol to drop, either, you know, in the morning and or after dexamethasone low dose suppression. That they want to see in order to consider it a true remission. Okay, so that's another important consideration, is both short-term and long-term. So the Pittsburgh experience, in their experience, they had 20% were MRI negative. And you can see here the NOSP, which as you expect, so these are MRI negative, NOSP low grade, NOSP high grade. And you can see that initial remission is going to be lower for the NOSP 3 and 4. And that is, again, that just goes to show you invasiveness, right? These are tumors that are more invasive into the walls of the cavernous sinus. And so you're going to get decreased remission rates for those patients that are NOSP 3 or 4, although they did not note this in a significant manner. For the MRI negative adenomas, the remission rates were about 80%, okay? 70% with surgery alone, and then that goes up to about 80% with surgery and adjuvant therapy. So again, just like in growth hormone and acromegaly, you're talking about surgery alone gives you a certain level of biochemical remission, and that you can always increase that with both medications and radiosurgery. I will just skip over this. This is just talking about what sort of, you know, patients who are older and females, and also your sort of pre-op levels of ACTH, which correlate with decreased remission, okay? Talk a little bit about other options. So these are just medication therapies, either steroidogenesis inhibitors, glucocorticoid receptor antagonists, or corticotropic directed agents. This is all your sort of, you know, your cortisol and all the different pathways that we can affect in order to get our you know, the medications are going to act on these different pathways. You don't have to know all of these, but you know, your endocrinologist, it's important if you're doing a lot of these that you do have an awareness of where these medications act and some of their side effects, because you have to work with the endocrinologist pretty closely to determine, you know, whether or not the drug is sufficient, whether it's working, or whether, you know, you have another option. In terms of radiosurgery, again, it takes a little bit longer to obtain remission. Same thing as for growth hormone, are useful for recurrent or residual disease. And as opposed to fractionated radiotherapy, again, These are going to have small volumes, so it is going to be useful. Same thing with the growth hormone ones. When you have macroadenomas and you have surgery, they're going to be decreased down to small volumes. So radiosurgery is really better than fractionated radiotherapy. And also one important thing to keep in mind is when you don't have discrete adenoma found on MRI, say you've done your exploration, you've haven't gotten a biochemical remission, you can do entire cellular SRS, right? Your pituitary dysfunction is going to be higher than your usual 25 to 40%, but you can do entire cellular SRS in order to try to get a little bit of biochemical control. And this is just another study showing that radiosurgery can be successful. Importantly to note that two things, you need a high dose, you need a high margin dose in order to achieve biochemical success. And again, it was the important thing, the one thing that made a difference in terms of remission after SRS was whether or not they were taking their medications. So you actually have to stop their medications at the time of SRS, and that will improve your outcomes. I think we're running out of time a bit here, so I'll just briefly mention prolactinomas, which you can have medication therapy. And the reasons to really operate for these giant prolactinomas are if they are resistant or the patient's intolerant. Very rarely would you operate for patient preference, although that is a controversial topic and it is increasing in sort of, it's becoming more common as we can do these things safely, and some patients don't want to be on long-term, lifelong therapy, or if you have, again, apoplexy with decline. Most of these large giant adenomas were invasive, right? So the NOSP grade 3 or 4. This is just sort of what was considered remission rate, both immediate and at follow-up. And biochemical remission, again, you have about 40% with the endoscopic approach alone, because again, these are the tumors that are gonna invade into the compartments, the paracellular compartments. They're gonna be the multilobulated ones. So your remission rates are actually gonna be a little lower. So they're 43 by endoscopic, by EEA alone, but you can increase that again with adjuvant therapy. And lower NOSP scores, less invasive, are also gonna be associated with improved remission. And the other thing, if you're pre-operative, just like ACTH, your preoperative prolactin levels being lower is also going to lead to improved remission. Again, making sense. Higher level of prolactins, more invasion, less chance for cure. Radiosurgery, this is one of the consortium papers, again, can be used. Again, higher margin dose. If your pre-treatment prolactin level was a predictor of endocrine remission, and increasing the margin dose was important here. So these are oftentimes going to be used for those tumors that have little lobules that you cannot reach surgically. Radiosurgery can sort of be another salvage therapy. I think importantly, I think perhaps most importantly, these tumors can be very complex, and it is important to have a pituitary center of excellence, which we do here. We're very lucky to have that. We meet, every other week. The MOBs, and this includes us, ENT, endocrine, ophtho, oculoplastics, OMFS. We need our radiation colleagues to be present. Pathology needs to be present. They need to be good at sort of telling us what they see under the scope. Under the microscope. Neuro-IR is very important, not only for inferior petrosal sinus sampling, but they bail us out, right? If we get a vascular injury, neuroradiology is important. Sometimes if you're not seeing, a pituitary, if you have an MRI negative pituitary tumor, you really do want to consider talking to an experienced neuroradiologist and see if they can do any of the dynamic or the grasp imaging to help you. Your neuro ICU team, the nurses, everyone taking care of them postoperatively is very important. And they've actually studied this, again, like all roads in pituitary surgery lead to Pittsburgh. They did study this, and they showed that teamwork in skull-based surgery leads to improved patient outcomes. And this is just our group here at the NASBS meeting in Orlando, I believe it was, or I can't remember where that one was, but either way, we have a great group of, great team, skull-based team here that really allows us to give our patients the best care. So if anyone has any questions, I'd be happy to answer.